Hey everyone, thank you for joining us today. Shaun, Brewster, Bodine, Ledden here today. Bo, we're going to have a chat about shoulders today. You are probably most well known for hip and pelvis and the knowledge around that area, but there was something that was the precursor to your hip and pelvis obsession, and that was the shoulder. Was that fair to say?
Yeah, I'm a ball and socket guy.
Ball and socket guy. That makes sense. That
Sho-
makes sense.
Shoulders my close second favorite.
Close second favorite. Not that we're meant
Yeah.
to have favorites, but that's fair. I'll accept that this time around. All right, so we're going to talk shoulders today, and I thought we might make this a bit of a Q&A, but I've got some questions for you, and I'm going to fire at you. Some things that I think will help to give people a broader and better understanding of shoulder pathologies, and hopefully help them become better clinicians at dealing with shoulder pathology. So let's kick off with the first one being, what do you see as the probably the three most common shoulder presentations that we see in clinical practice?
All right. As quick as you can handle this, you got rotator cuff tears, rotator cuff tendinopathy, and bursitis. Now, they're your really common ones that you'll see in chronic shoulder pain presentations. Now, they'll a lot of these presentations come under the umbrella of now rotator cuff related shoulder pain. So we're getting less and less specific. Often, many of these pathologies will coexist, and in our assessment, we can't use any real physical test to point out the cause. And in fact, obviously, when we look at imaging as well, we can't say that because they've got a tendinopathy or a rotator cuff tear that's the cause of their shoulder pain, because they are so common, and they're so common also in the asymptomatic population. So I've got to say, they're your three that you'll see day in, day out. Anyone that walks into your clinic with a shoulder-based pain problem, particularly, let's not talk about traumatic causes at this point, but, when you're looking at your chronic shoulder pain presentation, there's going to be some tear, tendinopathy, and potentially some bursal changes there. So what I'll say on bursitis as well, that's one that's often has the finger pointed at it all the time to say, well, you've got a shoulder bursitis. And the narrative behind that, or the perception, is that itis, meaning inflammation, rest, and ice, have a more of a passive approach there. But bursitis is nearly always going to be secondary to poor cuff function or rotator cuff pathology. So it's important that we understand that. And, when we look at even bursal thickening, that's a normal adaptive response to load. You often see this on imaging reports that there's subacromial bursal thickening. Well, that's normal. So we've got to understand that as well.
100%, yeah. And it's funny, isn't it? We see a lot of people with shoulder presentations, and you're right in separating out the traumatic from atraumatic ones, or insidious type ones. It's the more the insidious ones that sneak up on you over time, the ones that we see clinically. The traumatic ones go to the emergency room. Typically, I've broken something, I've torn something, I've had a fush, I've had something like that, and then it's managed in that setting. But for the allied health practitioner in the clinical setting, it's the people that have had the shoulder pain that's gone on for weeks or months, and then they come and see us. And you're right, we often see people presenting with, I've got a tear in my rotator cuff. Okay, how do you know that? Had a scan. Cool. I'm 44 years old. I also have probably about 5 of those, and I have no pain. And that's normal, right? Because as with normal age-related changes, we get these changes in the bursa, the tendons, the other soft tissues around the joint, and even the bones. We can have changes with no symptoms present.
Yeah, it's an important point. A patient will come in and say, I've done me rotor cuff.
I love that one.
Okay. And then you ask them a little bit, oh, which one? Oh, the whole lot of them. Yeah, so there are all of these sorts of changes that can occur. And in fact, as I said before, there's lots of these presentations that occur in the asymptomatic population. In fact, there was a study, I think last year, the year before, 96% of elite level rock climbers had at least one shoulder pathology. So yeah, we've sort of got to shift away from that biomechanical lens of pathology equals pain. There can be all sorts of changes, osteophyte formation, changes in acromion shape that's also not associated with symptoms. there can be arthritic changes and a number of different things. And a lot of the time, yes, they absolutely can be sensitive and painful, 100%. But they can respond really well. And it's not always due, we don't always need to see the pathology resolve or heal. Because that's, when you look at tendinopathy, for example, or even rotator cuff tears, that these can be normal age-related changes that occur, and they don't need to heal to have to be symptom-free. So when a patient has imaging and they goes, I've seen all of the tears and apparently it's the worst one they've ever seen, that narrative behind that is sort of that it's weak, it's vulnerable, it's likely to get worse. That tear will probably go and I'll completely lose all function of my shoulder. So yeah, it's really important to sort of educate our patients that, look, a lot of these changes are really common, and often we can get some really good results with these with conservative management over time.
Yeah, that's good. And I think that the focus on the word pathology is worth mentioning here too. We talk about these normal age-related changes, and again, we're separating traumatic from non-traumatic specifically, because if it's traumatic, someone tears something, breaks something, that's going to produce pain, and you can 1 + 1 = 2 in most cases there. But more of these chronic ones, when we see somebody who has some thickening of a bursa or changes in a tendon, and we call that the pathology, and you see we don't always have to see the pathology resolve. Well, in fact, we don't have to see the pathology change at all, and the person can have a complete resolution of their pain. And so their pain may be linked to something else, like you said. And so maybe what we need to do is start shifting the language away from the pathology related to the change in tissue, the pathology being the pain state, the presentation of the pain. And so what do we want to see? We want to see improved function. We want to see a reduction of pain, and we want to see a movement towards healthy range of motion and activities of daily living. The pathology, if we're focusing on the tissue changes that may or may not have occurred, is kind of irrelevant at a certain point. Not when it's acute, but at a certain point it becomes to a degree irrelevant, and then it becomes about those more functional changes that we want to see. The tissue can do what it wants. If we all scanned our bodies, probably the age 30 onwards, we would find dozens of pathologies, if you want to put it into that category, which is really just changes in the soft and hard tissues of the body related to the life that we live, and it doesn't really matter, or it doesn't have to matter in the same way that we may have been led to believe.
Yeah, I agree with that for sure.
Yeah, cool. Let's go to the next question then. What are some of the, and you might have touched on these already, but what are some of the common misconceptions we see around shoulder-related pathologies or presentations?
Biggest misconception by far is the impingement model, right? So, and it's still widely used today. And this is, we talk a lot about language, but the sort of impingement model really instills this biomechanical bony impingement of humeral head against the coracoacromial arch, and it's really outdated. So I think it was 1972. There's a Dr. Charles Neer. You've probably all heard of the Neer's test, and he believed that about 95% of all shoulder injuries were due to mechanical abruptment of the humeral head against that coracoacromial arch, causing a tear or that mechanical impingement. So, and that's just not true. It's been disproven now that impingement is normal. Yes, there can be sensitive movements, but if that model was true, then most of the tearing in the pathology would be seen on the outer surface of the tendon. In fact, most of the pathology is seen on the undersurface of the tendon. So this is that stress-shielded area. Or where we see these rotator cuff tears and tendinopathies, you might see this in a report as a partial thickness or a full thickness undersurface tear of the supraspinatus or infraspinatus. All right, so that whole impingement model is one of the biggest misconceptions. And the perception of what a patient thinks about is that, apparently they said there's two pieces of bone that are pressing against one another, so that's why I can't move my arm up above my head. All right. And so you think about their compliance with exercise. How would they comply with exercise if they think that there is a mechanical bone, a piece of bone or something that's stopping their arm from moving? All right. When, yeah, it's sensitive, but we've got to get them into this overhead movement and desensitize that movement, de-threaten their nervous system, improve their strength, improve their capacity, and get them back to the things that they enjoy doing. Because, yeah, we know that when we look at surgical decompression, that's where I was going with Dr. Charles Neer as well. So he did arthroplasties where he would shave away the undersurface of the acromion. And, the surgical rate of these arthroplasties rose by 752% in the UK over 10 years. So it was a huge increase. And what they've found is that there is now no difference between the surgical intervention at 12 months, 2 years, 5 years, and 10-year follow-ups versus conservative management. So it goes to show that, yeah, shaving away the acromion, in this impingement model, there's no difference compared to exercise. And one's a lot cheaper and probably have better outcomes anyway, as far as quality of life and all of that sort of stuff. So,
Sure.
Impingement model, that's a misconception.
Can we unpack that a little bit more then for a second? We often come across people with impingement presence, what would be normally termed impingement presentations through lifting weights, lifting load overhead. And then they say, yes, I'm getting impingement through my supra, infra, biceps tendon, whatever it might be. I went and saw XYZ person. They got me to train my lats and my rhomboids and my lower traps and my shoulder depressors. And as a result, I'm getting less elevation of that humeral head and therefore less impingement. My pain has improved. And so in that model of thinking, we could say that, well, by decreasing the amount of compression through humeral elevation, we decrease the amount of irritation of the tissues. People get better as a result of those specific exercises or manual therapy treatment that is aimed at decreasing the amount of compression. So where do we take that misconception and this idea and mix the two, because they don't seem to sit well together?
Yeah. All right. Well, let's put it this way then. They were prescribed this specific exercise program that they did and they were consistent with over a period of time. Did they reduce the amount of overhead work that they were doing for a period of time while they built up their capacity to be able to withstand that? When we look at conservative management for these presentations, it's a minimum 12-week progressive exercise program. So in that time, that's time to develop that tissue capacity, desensitize their nervous system, remove some of those provocative factors that then get them back to what they were doing. So whether they trained their shoulder depressors or, whatever they did, we've got to understand that it's probably just a type of load through that area that stimulated enough of a response to create some adaptation. When you look at that from a manual therapy point of view, yeah, you could be in a very biomechanical framework of, well, I'm pushing the humeral head in one direction to create space. Well, or are you just adding a different input that gets them comfortable with that particular movement? Are we desensitizing that movement and allowing them to move in a pain-free manner for a period of time? And then, educating them that, see, this movement is actually really helpful. You can do this without pain. What does that tell you about this mechanical compression of the acromion? If you can do that, in the space of this one session, what do you think that's really saying about your overall shoulder function and the possibilities going forward? So it allows the patient to question their beliefs and diagnosis and the narrative behind that impingement model.
So then what if we then look at it from the perspective of joint-specific posture? I don't know, we've talked a lot about posture, but someone goes, okay, I'm getting difficulty lifting my arm overhead. But when I do those exercises that my therapists give me to sort of set my scapula back and down and move, it's so much easier because I'm setting up the posture of my shoulder. I've got bad posture in my shoulder. When I improve that, my pain goes away. How can we correlate those two?
Yeah, well, that's just showing that that's a sensitive movement and a sensitive position at that time. But it doesn't mean that that posture is bad. It just shows that their shoulder is sensitive and moving in that position. And all as we're doing by changing that is symptom modification. So if we can change it and say, oh, try that, now reach up. Oh, that feels a bit better. Great. We modify symptoms for a period of time, but it doesn't mean that they always need to move in that position. It's just while they're sensitive. Let's find you a comfortable way to move for a period of time while we improve your strength, improve your capacity, and decrease your pain. But then let's introduce that position again, that position that was more uncomfortable. And, that's sort of getting people comfortable with what they're uncomfortable with. And that's sort of, that's really what it's all about, not saying avoid that position because this is the only way that you can move your shoulder. Like another outdated thing is scapular dyskinesis, that like saying that, oh, your scapula's moving it's not moving at that 2-to-1 ratio. Like that, we see all sorts of different variations in scapulohumeral rhythm in symptomatic and non-symptomatic people. And that their pain can change without the scapular movement changing as well. So yeah, I mean, if we're looking for biomechanical corrections all of the time, I think it's just about getting someone comfortable with movement and looking at what they're doing. What are those provocative and irritable factors? Backing them off, finding a comfortable way for them to move for a period of time as we build up their strength and capacity. I mean, Greg Lehman says it so well. Calm shit down, build shit up. So it's just about reducing their symptoms and progressively integrating, those uncomfortable movements back into their training and movement.
Yeah, that makes sense. But I do hear all the powerlifters and CrossFitters and load-based athletes crying in the background saying, but hang on a second, I've been trained for good technique, and when I use poor technique, which could be termed as the inappropriate or sensitive posture, when I improve my technique, I am able to lift heavier. So would you say it's fair to say then that there's no perfect posture or joint positioning for the purposes of being able to move pain-free? But if you want to be more efficient at pushing things that are heavy, lifting things that are heavy, moving things that are heavy, then there is a more ideal way to move when you are loading yourself to a higher degree.
Yeah, well, pain and performance are two completely different things, and we shouldn't really confuse that because yes, there are more biomechanically efficient ways to do things, but people that are not very biomechanically efficient can also have no pain at all. So it's really when we're looking at someone who is in pain, how do we modify their symptoms? And that doesn't need to be in a perfect posture of, perfect scapulohumeral rhythm or, limited movement through the glenohumeral joint, whatever it may be.
Yeah.
Like there's certainly, like if you're like you said, a high-level powerlifter, then there is a technique where you're going to be able to generate the most force with a bench press, for example. But again, different to pain. If they had pain, then it's just about modifying their symptoms for a period of time. And it might be that if we need to improve their performance, then we're looking at very specific changes in biomechanics. But if we're looking just to get someone out of pain, we just need to get them moving. We just need to get them comfortable with movement.
Yeah, no, that makes sense. Good. Okay, look, the shoulder is one of those areas that is fraught with these misconceptions, right? There's all these, there's plenty of people out there who claim to be the experts on shoulders, and I think that there's a lot of so-called experts or gurus in every region of the body, and we all as humans have our own biases, and if we have done something for the last 10, 15, 20 years and it's worked for us, we believe it to be true. And I think this can be said about any part of the body with any approach that we use, assessment, treatment, it doesn't matter. And so I think what you're saying here is common sense. It's looking at the human body from a perspective of acute versus chronic presentations. They're two separate things. We're looking at the body from pain versus performance. They're two separate things. And it would be very easy to someone to listen into this podcast and take a 30-second, 3-minute snapshot of something and go, Bo is not the biomechanics guy. He doesn't think about technique. He doesn't think about posture. He's just all about the pain and pain science. But it's not true, right? It depends on which lens you're looking at the patient with and which patient has walked in the door. Are they someone that just fell on their shoulder? Or are they someone who developed shoulder pain working at a desk, for 10 hours a day for the last 3 months, and that's something that's hurting? Two vastly different presentations that would take two vastly different assessment and treatment approaches.
Yeah, I used to be all about biomechanics. That was my lens. And then, I'd had people that had this perfect posture, they had this perfect movement, they were strong, all of this sort of stuff, but they had pain. And you scratch your head and think, hang on a second, what's going on here? Something doesn't quite add up. So there's much more to it. Pain is multifactorial. We've got to have a look at some biomechanics. We've got to look at these various other psychosocial factors and the multidimensional nature of pain. But I don't think it's just one or the other, and that's why we can't just pull out one thing and say, well, that's what it is. You've got a supraspinatus tear. That's the cause of your pain. And to fix that, you need to do, these specific exercise. You need to sit in this perfect posture. It just doesn't work like that.
There's no one size fits all, right?
Yeah.
And we see this over and over. Okay, so for all the people who are listening to this going, damn, all right, that's not how I've been working for the last 5, 10, 15, 20 years, whatever, 5 minutes, or however long I've been a practitioner for. So I want to get better at this stuff, but everything I read tells me one thing, and then I read something else and it tells me something else, and I read the research and it tells me 5 different things. What advice would you give to a practitioner who wants to be a better shoulder therapist, wants to get better at this?
Yeah, look, there are some really good resources out there. Jeremy Lewis's stuff, he's really good. He's got some good publications. But yeah, you've just got to dive into PubMed and really spend some time looking at some of the literature. But yeah, try to, I guess, put some of that biomechanical structural framework sort of stuff off to the side for a little bit and look at just getting someone moving, aligning that with their goals. What do they really want to do? And again, this will depend on the patient. What do they want to get back to? What do they believe is going on in their shoulder? And that way we can start to dispel some of these misconceptions and myths around, impingement or some structural abnormality that's stopping them from moving. De-threaten their pain experience and what's going on in their shoulder, and just getting them comfortable. But I think the important thing to remember when looking at shoulder pain and rehabilitation is that it's a slow process. All right, we can't expect to see significant results immediately or even in a couple of sessions. I mentioned before, it's you want to have a minimum of 12-week progressive exercise intervention, but it could be 6 months, it could be 12 months. It's about just progressively increasing their load over time. And, when I talk about load and strength and all of that sort of stuff, at the end of the day, it still should be something that they enjoy doing. If they don't like going to the gym, find something else that they can do that can load their shoulder.
Yeah.
But also, when you look at good quality exercise, get them doing something with relatively heavy loads rather than just this green TheraBand exercise that can just potentially waste their time. I mean, there's a place for it, but I think when we look at good quality exercise, get them loading it up with relatively heavy loads over a period of time.
Sure. Now, you mentioned that it's a minimum of 12 weeks, for a resolution. Should we qualify that and say 12 weeks for return to normal or prevention, maybe is a better way to do it, resolution and prevention of this situation? Because I've certainly seen lots of shoulder problems where in 1 or 2 sessions I've dramatically decreased their pain and increased their function. But that might not be the solution. That might be the symptom modification. And then the exercise and the other interventions, the activities of daily life modification these things happen over a longer period of time. Yeah, they're the things that take that 12 weeks to get you to the point where, okay, now I'm clear of this problem and I'm not likely to return to it in the short term.
Yeah, 100%. That's right. You can certainly have some good results early on, but it's also having that conversation with the patient. Look, are you ready to commit to this? Can we make a deal that we're in this together for the next 12 weeks where we can progressively increase things? Because in the first 4 weeks or so, when you look at applying a stimulus and allowing time for adaptation, you're not going to have a huge amount of adaptation in the first few weeks. Certainly it can be enough to decrease some pain and improve some function, absolutely. But, it's that real journey where we need to then increase the amount of load that we're putting through it in another 4-week block and then another 4-week block. So it's progressive over time. If we say, look, we want to get you back to full function or as close to it, this will be a bit of a journey that we take together. And also knowing that it's not always about getting them completely pain-free, because that doesn't always happen either. So sometimes if they've got the expectation to be completely pain-free, then what you're offering may not align with their expectations. Sometimes there will be some residual pain and there will be some ups and downs. But overall function and overall quality of life and overall levels of irritability should progressively increase over time. But yeah, I think it's to get some good adaptation and some good changes to the shoulder and their pain and function. I think a 12-week time frame is pretty good to start with, and you can always modify from there. If you need more or less, and understand what barriers that may have affected them getting to that goal in 12 weeks or whatever.
Gotcha. Yeah. And I think it's probably worth also mentioning to the manual therapists out there that this is not 12 weekly sessions, for 12, once a week for 12 weeks. It's a period of time for the body to adapt to the stimulus that's being applied. That might be 1 or 2 sessions in the first 1 to 2 weeks. Then it might blow out to the next session is 2 or 3 weeks later. Then it's 4 weeks later. And then the last session is at the very end. It could be 4 or 5 sessions total, but it's the time, like exercise. You can't go to the gym once and get strong. You've got to do it over a period of time. So it's the time that we're factoring in here, not the number of consultations. And that's the trick, right? You don't want to be, okay, well, this is going to take 12 weeks. And the patient immediately thinks, I have to come back every week for the next 12 weeks. No, it's going to take you 12 weeks to get strong enough that we see the changes in the tissue that we want to see and the changes in function that we want to see. It might be that I see you in the short term a couple of times, and then it's a phone call or an email to check in with me, or it's a one consultation in a month and a half. And it's, you can space it out based on the patient and their needs, the level of support and guidance that they require, and the start and finish point of that progression that you're looking at.
Yeah, that's a great point. Like you said, might be a higher dosage of treatment early on, but then it could be, let's come in and we'll update your program. I want to see where you're at, and then we've got to test them from there. What can you actually do? Because if we're not applying or providing strength exercises that are challenging, then it's not going to be enough to stimulate an adaptation response. So we've got to really challenge them, see what they can do, push them that little bit. And I think that's the real importance, because you would imagine if you went to the gym and did 5 kilo bicep curls for 12 weeks, at the start you might get a little bit stronger, depending on how strong you are to begin with. But then, over time, then you'll just adapt to that load. But if we progressively increase it, so that basic principle of progressive overload, applying a stimulus that's slightly above what they're normally used to, over a period of time, that can be really important. So yeah, check-ins, give them a call every couple of weeks, just seeing how you're going with that program. It makes them accountable as well, because otherwise it's, oh no, I was really busy on the weekend. All right, no worries. Let's get you back into it. Let's not leave it too long, but get back on the horse.
Yeah.
So check-ins are a great idea.
Makes sense. Perfect. All right. Well, that's really good. I think that's we've knocked a few misconceptions on the head. We've talked about some of the key anatomical understandings and beliefs that exist around shoulder presentation. Then there's some tips for people who want to get better at this. Is there anything else you'd like to throw in there before we finish up?
No, I mean keep doing what you're doing. Like I said with the surgical approach, conservative management is really effective. So from a manual therapy point of view, it can be great as far as symptom modification goes. If you're not doing much of the strength work, then either refer out to someone who does, or start to integrate that in, because that's a huge part of their overall recovery and the good long-term outcomes. But yeah, I spoke quite a bit about exercise, but manual therapy can be a fantastic way to modify someone's symptoms, reduce their pain, and provide them with a window where they can go out and do their exercises and have less symptoms in that period. So you can see how that can compound over time.
Yeah, and it's interesting you highlight the difference between the connection between manual therapy and exercise. And I know at ACE we often get lumped into the manual therapy guys. Well, we see manual therapy in the perspective of there's the hands-on skill set, there's the exercise component, and there's the pain science, education, communication component. We see all of that as sitting within the realm and the scope of practice of a good manual therapist. You don't have to be just the person who puts hands on for an hour or 30 minutes or whatever your consultation time is, and then refer on. If you don't have the skills for exercise and the skills for understanding pain science and education, those are skills you can acquire. That is information that is available to you and is certainly within your scope of practice to deliver. And then you just need to get good at that. If you're not good at that, that's where you co-manage. But yeah, I don't think any of us should think about all of these components of patient management as separate. They're all part of what helps get patient from A to B to C and so on.
Yeah, definitely. And sorry, I do have to say one more thing.
Go for it.
Because I sort of touched on corticosteroid injections, and these are things that often patients will want to have. They've heard that they're really beneficial, but corticosteroids can have a destructive effect on the tendon matrix.
Mm-hmm.
So in numerous studies, they've shown that they may provide short-term relief, but they're actually worse in the long term. So if patients are coming in with, they might have said they've had one, they might have said they've had two, they might have said they've had five. In fact, there's research that suggests that people who have had corticosteroid injections are far more likely to have more corticosteroid injections. They're more likely to have more repeat visits to their primary care health provider, and they're more likely to have worse outcomes. And it's also far more expensive. So understanding this stuff is really important so that we can educate our patients about the benefits of conservative management. I think that's really important. Like manual therapy, the exercise can be fantastic, but we do need to sort of be aware of the potential negative implications of corticosteroid injections and educate our patients about the risks versus the benefits.
Yeah, no, I 100% agree. Shoulders are renowned for having the jab, right? Just go and get a jab, it'll sort it out. And it is the lazy man's approach to resolving a soft tissue-based pathology. And I guess it's unfortunate that fortunate and unfortunate, in some situations, people get some reduction in pain, right? And they go, oh, this is great. It's really good. But then 6 months later, they're back again with the same problem because they didn't resolve the source of the problem. They resolved the symptom. And so when we talk about symptom modification, it is a means to an end. It's not the end. Whether it's a corticosteroid injection, a change in position while we're lifting, some tape, a dry needle, whatever the thing is that modifies the symptom, that is the means to the end. It gets us to step B so that we can then incorporate more movement, incorporate more better awareness, incorporate more strength, and build towards the solution. It's not the ends in itself. So yeah. Great. All right, let's wrap it up, Bo. Thank you very much, everyone, for that. That was great. We'll see you on the next episode.
Yeah.